Hello everyone, I am Dr. Saurabh Dikshit, and as per promise, in the clinical series of surgery, I have got one more interesting case for you. So today I have a patient who has been admitted in my hospital and the diagnosis of acute appendicitis has been made. So do you know that what is acute appendicitis? It is nothing but inflammation of the appendix. And when we talk about the inflammation of the appendix, what are the reasons? There are two probable reasons. Either it could be because of the inflammation and there is swelling, that is what is known as a catarrhal type, which is very common in the rainy seasons. So when we talk about the seasonal incidence, yes, during the monsoons it is the maximum. And the second important cause is a fecalith. You know, in fact the fecalith is the most common cause. 80% of the appendicitis are due to fecalith. Now what is fecalith, students? It's a hard stone like stool. So this is what is a fecalith, which blocks this tubular appendix, and when it blocks, the inflow and the outflow, yes, gets jeopardized. And since the appendicular artery is an end artery, there is a risk of perforation. And do you know, when the perforation happens, the scenario worsens. So when we talk about this patient, what are the clinical features that we look for? How we'll make the diagnosis? So ideally we have to go for radiological assessment, or we have to go for the clinical assessment. But this appendicitis is the only condition where based on the clinical evaluation you can go for the surgery. Why? Because these symptoms are roaring. So when we talk about the diagnosis, there is a score which is known as Alvarado score. When we talk about Alvarado score, what does it mean? Alvarado score looks for some clinical signs, some clinical symptoms, and along with that we have some biochemical findings. So when we talk about the clinical signs, now let me ask the patient, hello, आप मेरे को ये बताइए कि आपको क्या तकलीफ है? पेट में दर्द है. So can you just focus here? Can you just focus? कहाँ पर दर्द है? So this is the right iliac fossa pain. This is what is very important. This is right iliac fossa pain, and to this we give a score of 1. So इसके अलावा apart from that, क्या आपको उल्टी जैसा महसूस हुआ कभी भी? Okay, so there is a complaint of vomiting or nausea. So again, Alvardo's includes nausea and vomiting. Along with that pain, आपको भूख लग रही है? So this is again anorexia. So students, try to see, these are the classical clinical features. So we have anorexia in this patient, we have nausea, vomiting is not there, but nausea is there. Then again the patient is having right iliac fossa pain. Now when we want to add the biochemical things, we will go for leukocytosis and CRP also, or a left shift in the neutrophil. So these are the biochemical things. Apart from that, one very important thing that we need to understand is the clinical symptom we have seen. Now the signs. When we talk about the sign, this is the umbilicus and this is ASIS. So this is the line, this is the spino-umbilical line. Now just see, 2/3 medially, 1/3 laterally, this point is a McBurney's point. The moment I press, just see the reaction of the patient. I'll just be very gentle, just see this. Just see, the moment I press this, can you focus here? And just the moment just see the reaction of this patient. So this is a classical McBurney sign, and which is very important here. Apart from this, there are other clinical signs. We have a Rolfing sign. What is a Rolfing sign? Now I was doing the test in the right iliac fossa. If we do the very same test in the deep palpation on the, you can say, on the left side, will give a rebound tenderness on the right side. So rebound tenderness is not seen because this patient might have started with the symptoms very early. ये दर्द आपको अभी शुरू हुआ होगा? So this is an early phase of appendicitis. So the rebound tenderness is still to develop. Yes, if it would have been a big appendicular lump in this case, the rebound tenderness would also have been present. It is because of the, you can say, when I press here, there is more lateralization of the right side viscous, and it causes the appendix to touch to the, you can say, parietis, and this causes the peritoneal reflection of the pain. That is why there is right iliac fossa tenderness. Apart from these tests, we also have two other tests. So sometimes, you know, the appendix might be pelvic. So for pelvic appendix, you have to go for a Swas test. Now what is a Swas test? आप अपने दोनों पैर इसको बिना फोल्ड करे उठाएंगे, दोनों पैर. So can you experience the pain? आपको दर्द महसूस हो रहा है? So yeah, okay. So बस इसको. So can you see the pain over the hypogastrium on elevation of both the limbs? This is a classical Swas sign. Apart from this, there is an obturator sign. What is an obturator sign? Let me show you. So मैं आपका पैर फोल्ड करूँगा. I'll fold your leg like this. ऐसे मैं. So you have to fold the patient's leg and then you have to rotate the knee outwards. So this will cause the pelvic rotation inwards, and now this is not positive. So obturator is not positive. Had the obturator been positive in this case, the patient would have again had a pain over the hypogastrium. So this is what is something about the Alvarado score. A clinical assessment when we do, if it is more than 7 positive points or score of 7 or more, this is indicative of acute appendicitis. Now this patient has also undergone a CT scan. So whenever we talk about a CT, this is what is very important. So you are seeing there are two sections in the CT. So this is the case, this is the place where you have the liver, and this is the place where you have the cecum. So in this case, you'll have a blind non-tubular loop. So actually when we talk about this CT, what is the problem with this CT? This CT was done outside. This is with an IV contrast. Had this been with oral contrast, in this area you would have seen all the bowels full with the contrast except for a blind loop. So this patient should have undergone CT scan with an oral contrast. However, this was done outside our hospital, so we couldn't comment on that. But yes, whenever you are having a slightest of the diagnostic dilemma, you always have to go for what, students? CT scan with oral contrast. Now, when we are planning a management, now this patient has already been planned for laparoscopic, you can say appendicectomy. Now, when we are planning the management, what is very important, one very important thing is that you will have a superficial assessment. Now when you talk about superficial assessment, can you show here? What am I looking for? I am looking for any palpable lump. So I cannot detect any significant lump. What is the significance of the lump here? The significance of lump is that the appendix is densely adhered with the bowels, and if it is densely adhered with the bowels, this is a high time that you don't operate. Rather go for an Ochsner-Sharon regimen, which is a conservative management. Reassess the patient after 3 to 5 days. Still, if the patients are present, then you will have to go for a laparotomy, because this patient might require a hemicolectomy. In that case, this might happen. One very important thing that you need to understand is when you are doing a laparoscopic appendicectomy, the planning of incisions is very important, the planning of port position. So let me tell you, students, this is the target. This is the target that we have. Now whenever you place the ports should come in between the two arcs. What are these two arcs? This is an 18 centimeter and this is an 24 centimeter. So in between these two arcs, your port should be there. So when we talk about the port positioning, why it is so? Because the standard adult laparoscopic instruments are 36 centimeter. To maintain the effort arm and the load arm distance as equal, so we need a class 1 lever where effort arm and load arm are equal. So you need to put these instruments in between these 2 points. If you go away from these points, the problem is that you might land up with either overshooting or undershooting. The next is, so here we will have the camera port, we will have the supra, you can say umbilical camera port, and there are two possibilities. You can have the ipsilateral port positioning or contralateral. Generally, the female surgeons or the surgeons who don't have a big, you can say, arm span, they prefer to go for ipsilateral port positioning. When we talk about ipsilateral, we will have the two 5 mm ports here. The problem with the ipsilateral port is the manipulation angle decreases. So if I have to operate like this, it is more, you can say, cumbersome because ergonomics are disturbed. The people like me or people with broad shoulders, they prefer to go for a contralateral port positioning. Now what is the advantage with contralateral port positioning? If you see the manipulation angle here is roughly 60 degree, and if you see here it is 30 degree. So I get a wider, you can say, flexibility to operate on these patients. We generally don't prefer to go for open appendicectomy because nowadays the open appendicectomies are not done. However, if you have to do the classical incision, this is the classical incision that we make. This is a McBurney's incision. You can have a more cosmetic incision. This is the Lanz incision. And apart from that, you have a straight incision which is known as Fowler. This is known as a Rocky Davis. Now, many a times when we are doing an open surgery, the space could be a problem. So we might go for a lateral extension. If we go for a lateral extension, what is this known as? This is known as Rutherford-Morrison. So Rutherford-Morrison is a muscle cutting incision, whereas Lanz, McBurney's and Rocky Davis, they are muscle splitting incision. If you go for a medial extension, this is known as Fowler-Weir extensions. So students nowadays, instead of going for these extensions and devastating the anatomy, it's better to do a laparoscopic surgery where you get abundant of the room. I hope I'll make a second part of this video when we do the surgery for this patient, and I'm very thankful to my patient who allowed me to just show the students the clinical, you can say, signs and symptoms and the inspection findings. Students, we should be respectful to our patients because they are the only one who are helping us to learn. And this is for not me, this is for you people. I have made this video, I have requested him so that we can have the students to learn what are the classical clinical signs, because just knowing about them is not important, learning about them is important, because now you have the next round the corner. The next is very important. So in that, the clinical significance of all these things is important. So I hope you enjoyed this video. Stay tuned for my next video also. Thank you.